Thank you for joining our webinar, which will provide an introduction to the World Health Organization's work in developing and implementing scalable psychological interventions. I'm Dr. Lata McGinn, here today as president of the World Confederation of CBT, otherwise known as the WCCBT. Before I introduce Dr. Kenneth Carsewell and the webinar, I'm going to spend a few minutes sharing what the WCCBT is and why we're here today. Dr. Carsewell will then present following that, and at the end of his talk, we will take your questions, so please feel free to write it in the chat. The World Confederation of Cognitive and Behavioral Therapies is a global multidisciplinary organization. It's comprised of 8 associations, ABCT and CACBT together representing North America, EABCT representing Europe, ALAMOC representing parts of North America as well as all of Central and South America, AACBT and ANZA-CBT jointly representing Australasia, ACBTA representing Asia, and IACBT. Well, broadly, the mission of the WCCBT is to promote and advocate for global mental health and to facilitate the development and dissemination of evidence-based practice through the formations and collaborations and partnerships with individuals, organizations such as the World Health Organization, and governments. The key priorities we have over the next 3 years of my presidency are to support the dissemination of CBT in underserved areas, particularly in Africa, where we need the growth, to disseminate the training guidelines that we have developed in partnership with our member organizations, and to partner with the World Health Organization and governments on disseminating competently delivered evidence-based practice. We have signed an agreement with the World Health Organization to collaborate on these common initiatives to increase treatment competency and disseminate evidence-based practice across the globe, particularly in underserved areas. Despite the proliferation of evidence-based psychological interventions and other effective services in global mental health, the vast majority of people still lack access to evidence-based mental health services, even as the mental health challenges continue to climb. The World Health Organization continues to do a remarkable job addressing various mental health challenges globally, in particular by using task-sharing approaches, where trained and supervised non-specialists deliver evidence-based interventions. We are delighted to have Dr. Kenneth Carsewell here today to present to us. Dr. Carsewell has a background in clinical psychology in the United Kingdom, and he is a mental health specialist in the World Health Organization's Department of Mental Health, Brain Health, and Substance Use in Geneva, Switzerland. He is a department focal point for innovation, digital mental health, and scalable psychological interventions. Dr. Carsewell has been centrally involved in the development, testing, and implementation of the WHO's Scalable Psychological Interventions for populations affected by adversity. These include Self-Help Plus, a multimedia stress management course, and step-by-step and online self-help intervention for depression, which is available as a free service across Lebanon. Most recently, he has led the development of a guided self-help chatbot for adolescents and youth called STARS, which is currently being tested in randomized controlled trials in Jordan and Lithuania. Dr. Carsewell is here today to talk about the WHO's work in developing and implementing these interventions. His presentation will provide an overview of the work of the World Health Organization in this area. This includes updated recommendations, the WHO's Psychological Intervention Implementation Manual that supports the delivery of non-specialist interventions, and various evidence-based psychological interventions that are open access, available in multiple languages, and are designed for use in a range of settings. He will also provide examples of how these interventions are being used in different settings. So I would love to have Dr. Carsewell educate us for the next 45 minutes, and then we will take questions from you all.
Right, thank you, Dr. McGinn. Thank you for the lovely introduction, and thanks to the WCCBT for the opportunity to give this talk. It is a real pleasure to be here, and it's a pleasure to be able to introduce you to some of the work of WHO. I know that last year, one of my colleagues, James Underhill, gave a talk on the EQUIP project. So this is a really nice opportunity to now talk about one of the other sides of our work, which is the psychological interventions. And I'll be touching also on EQUIP, but really the talk here today is really about focusing on the interventions themselves. So I'm just going to share my screen and then we'll make a start. Okay, where's the... Okay, so you can hopefully all now see my screen. Okay, good. So I'm going to give you an overview of our work in this area, because I think a lot of it will be relevant to many of the people watching today. We're going to start off with a little bit of an overview of the evidence and the context of this work. I'm going to give you an introduction to the different scalable psychological interventions that we've published, and also a bit of background on them. Talk maybe a little bit about ensuring quality and a bit about implementation, particularly with a focus on the psychological intervention implementation manual, which we released earlier this year. Now, the work on psychological interventions at WHO started, I've been there now, I think about 9 years, and it started before I arrived. So it's probably been going on now for a good 12, 13 or 14 or so years. And really, we started this work because there were recommendations around the importance of psychological interventions, and we wanted to bring these sorts of interventions, make them very widely available to different implementers. And I guess over time, the work has expanded, and we now sort of see that we have 3 pillars to this work. The first pillar being the interventions themselves, the second pillar being guidance around implementation, and the third pillar being around quality, which is the EQUIP project that was discussed in the last webinar. Now, all of this work is, and everything I'll cover today, is all available as open access and for free on the WHO website. A little bit of a long hyperlink, so the easiest way to get there is by searching WHO psychological intervention. So let's just talk a little bit about the evidence and the context around this work. So really the context is that globally we have a large mental health treatment gap. And I think really no matter what we do, we'll never have enough therapists, enough counsellors, psychologists, or highly trained individuals to deliver psychological therapies and psychological interventions. And as was mentioned in the introduction, a main part of this, a main part of a potential solution is really what we call task shifting, which is when you have trained and supervised non-specialists providing the type of support that a therapist or a psychologist or a CBT therapist would provide. And this idea of task shifting and having non-specialists deliver interventions has been something where the evidence has really been growing over the last 20 years. So really over the last 20 years and a little bit longer, we've seen more and more research trials in different contexts showing that non-specialists can effectively deliver psychological interventions. The other important part of it is that we sort of see that these scalable, or sometimes called low intensity interventions, can be effective for severe emotional problems. So we're not just talking about these being applicable to mild depression or anxiety, but they can be suitable for much more severe issues. And really, I want to just start just by mentioning that these ideas of task shifting. We use them obviously at WHO. Sometimes people might look at these ideas as being the types of approaches that you might use in a low middle income country. But really, one of the biggest examples of task shifting in psychological intervention really comes from the Improving Access to Psychological Therapies program, or IAP, in the UK. And this was launched in around 2008. It's been going many years now. There's over 1 million referrals each year. And basically under the IAP system, you have a system of stepped care. So people will be delivered progressively, intensively more treatments, more intensive treatments, depending on need. So, and with the first stage of that being delivered by someone called a psychological wellbeing practitioner, which is a university graduate who's been through an additional training for, I think, about a year to deliver things like guided self-help, maybe basic forms of CBT, and other interventions. And it's been a very effective system, and a large number of studies have shown that it's been effective. So that's really just to give the context that we're talking here about something that can be used in many, many different health systems, regardless of the income level and regardless of the resources available. So what might low intensity or more scalable interventions have in common? Well, on the left, we can see what we might consider more conventional psychological treatments. They're usually delivered by specialists. There's perhaps maybe one treatment manual per problem. They often require many sessions. They might require diagnostic assessments and similar. And if we think about more scalable versions, they usually rely on some form of innovative delivery, perhaps sort of IT, self-help books, videos. It might be possible to take a more transdiagnostic approach in one manual. They may not require a diagnostic assessment, and usually they require fewer sessions. And perhaps a big aspect of it is a focus on self-management. And this isn't true for all interventions like this, but these are some of the characteristics that we might see in such interventions. Now, in terms of what psychological interventions WHO might recommend, we released late last year an updated guideline for priority M&S, or mental, neurological and substance use disorders, in low middle income countries. So we have a set of guidelines that outlines the types of treatments that should be available for people with priority conditions in different countries. And in this guide, you will find a whole list and a whole range of different psychological interventions that are recommended. And these are summarized in the manual that you can see next to it, which is the Psychological Intervention Implementation Manual. Okay, so now I'll give a little bit of I've sort of given a bit of an introduction there into the wider situation. But now I want to talk you through more the actual work we've been doing at WHO and the interventions that we have available. So I touched on this a little bit earlier, but I suppose a real big question is, well, why did we start work in this area? Well, really, I think it comes from a place that even though there's been extensive research, there's been many trials, if somebody wants to get their hands on an evidence-based manual, it can actually be very difficult. So often what happens is the research is completed, the manual might be published, or quite often they're not. And then actually getting hold of that manual can be difficult. So even though there's extensive evidence, there's been quite an issue with actually trying to get hold of evidence-based interventions. We wanted to work to support the wider mental health community with this issue by making available these manuals and really creating the conditions to bring these interventions to scale. And one important aspect of that is providing the manuals as open access, which we can do through the WHO press and by having them on the WHO website. And we also wanted to accompany these manuals with implementation guides, training guides on how you adapt them for different cultures and different communities, supervision materials, and other materials that might support quality. And in designing and developing a lot of these interventions, we were really sort of seeking to find things that were going to be relevant for many populations and many different settings. And some manuals we developed ourselves at WHO in partnership with many different colleagues and collaborators. And some, such as Thinking Healthy and Group IPT, we worked with the original authors of the manual to create and publish it through a WHO version to be published through W.H.O. I'm going to talk you through quite a few of these different interventions today. Now, a very other important aspect of it is that all of these interventions are based on high quality randomized controlled trials. And we have aimed to complete at least 2 trials and have full positive results from 2 trials before releasing them. And here is just a bit of a sample of some of the randomized controlled trials that underpin a lot of this work. So as you can see here, there's been a wide range of different formats. We've tested interventions at group, individual, digital. We've tested in a number of different countries, a number of different regions, and also with populations that are affected by different forms of adversity. And we've always aimed to test the interventions with populations affected by adversity. So, for example, asylum seekers and refugees, people who are displaced by war, people in conflict area, and similar. And this again is just a little bit of a sample of the some of the places where we've tested the intervention. So you can see that we try and test them in a range of different settings. Now, we have developed a number of different psychological interventions, all which are available as open access. And in the psychological interventions implementation manual, there's a table that summarizes all of these. Now, these aren't obviously the only evidence-based interventions out there. There are many others, and there are many others being tested by different colleagues around the world. And really, I suppose at WHO, our position is that we want to see evidence-based psychological intervention being used. So it's not just the case that these are the only ones there. It's really just about these are there as open access and available for many people. And also maybe some of them, for example, some of the self-help interventions that I'll talk about in a moment, have been designed to maybe try and meet the needs of a larger population. So we can think about the WHO interventions really across a continuum, going from lower resource intensity, the lowest being something like an unguided self-help. So for example, a self-help book or a self-help app, going all the way up to specialist delivered interventions right here on the right-hand side. And here are some of the WHO interventions laid out across this continuum. And as you can see on the left, there are two there. One is step by step, the one at the top, and doing what matters in times of stress, which are sitting in the middle. And that's because they can be delivered both as unguided self-help and as guided self-help, which I'll come on to later on in this talk. Now, are these sort of low intensity or scalable interventions enough? Well, generally not. You know, we can think about the idea of step care. So, for example, when delivering support, we might first offer some form of sort of self-help or lower intensity intervention. We may then rescreen to see how people have improved and whether they need further support. And if further support is needed, then they can be stepped up to the second step. And obviously, depending on the area, depending on the context, the resources available, these steps may differ in terms of what is available. And the second step, or perhaps even the third step, might be specialist delivered intervention. And one thing that we see from using these interventions is that rather than sort of decreasing the need for specialists, it actually increases the need because it tends to sort of produce more referrals. It means that we use more specialist resources in a better way. For example, we can use them for more complex cases. And I think we would also sort of say it enhances the status of psychology and mental health within health systems. So now what I'm going to do is spend a little bit of time just giving you a brief introduction to each of these psychological interventions, just to give you a flavour of the types of things that are available and the types of problems they might cover and also the types of delivery methods. So the first one I want to talk about is the first one that we developed at WHO, which is something called Problem Management Plus. And there'll be the sorts of techniques here will be very familiar to people on this webinar because it follows very much a transdiagnostic cognitive behavioral therapy problem management type approach. It's 5 sessions, so we have 5 individual sessions. There's also a group version, which again is 5 sessions. And it uses primarily problem-solving counseling or problem management, along with behavioral strategies, behavioral activation, stress management, and strengthening social support. It's been tested in a number of different trials, and it's now been used widely in many different places, including adaptation for use remotely, online, over the telephone, and similar. And there are many places now where it's been scaled up. There's a project in Switzerland, where I'm based, where it's been scaled up to provide support to refugees across the whole of Switzerland. It's been used in many other countries, including Rwanda, Peru, Mexico, and Malawi, and for Venezuelan refugees in Colombia. So it's been used very widely. It's also being used at the minute in a project in New York. So we're also seeing a lot of these interventions being used in higher income countries with marginalized and in need groups. So the second intervention I want to just mention is early adolescent skills for emotions, or EASE. And this is aimed at young adolescents from about 10 to 15 years, primarily with internalizing problems. And it's also for the young person and their caregiver. It's delivered in group sessions to the adolescents with additional caregiver sessions. And again, it follows a similar sort of approach or similar strategies as we mentioned in PM+, for example, identifying stress management, behavioral activation, and so on. And there's a storybook that goes alongside it to help guide through the group format and the group session. So it's delivered by non-specialist facilitators over about 7 sessions for adolescents and 3 caregiver sessions. And I should mention at this point, all of these interventions that I'm talking about, when we've tested them in trials, they've been delivered by non-specialists, and they're designed to be delivered by non-specialists. And when we're talking about non-specialists, it can mean many different people: community health workers, peer volunteers, university students who have finished their bachelor's, people who have finished high school. And we've used many different groups of facilitators and implementers throughout trials and implementation of these different interventions. And the next one I want to mention is Thinking Healthy. Now this was actually the first intervention that we published. Problem Management Plus was the first one that we designed and tested in trials. But Thinking Healthy, we worked with the original authors of this, Professor Asif Rahman and his colleagues, to basically publish a version of it that was open access under W.H.O. And this is aimed at mothers with symptoms of perinatal depression. It's designed very much for integration into maternal and child healthcare. And it's designed to be delivered by community health workers, very much based on CBT principles. And there's a number of places where this has been tested and implemented. And then we have another intervention, which is group interpersonal therapy, or group IPT. And we decided to work with Columbia University and colleagues there, Myrna Weissman and Lena Verdelli, to publish a WHO version of this manual. This version is based on 8 sessions. It's group-based intervention. There are around 6 to 10 members per group. And it follows very much an IPT approach. So it looks at the different problem areas that you see in IPT. And there's a big focus on the current reasons for depression, and also links between depression and the different problems that might influence relationships and issues. And it's been scaled up widely, particularly in Uganda. It's been used throughout Uganda in many different communities. So all of the interventions that I've talked about so far really are interventions that are group-based or individual-based. So it's very much about, a facilitator or provider talking one-to-one to a person, or providing a group. And now I want to talk a little bit more about the parts of the interventions that are on the left-hand side of the scale. So the more self-help interventions, because we see that these interventions, the sort of self-help interventions, have the ability to provide support to much bigger populations across much bigger areas. I'm going to go through a few of those now. The first one I want to mention is something called Self-Help Plus. And Self-Help Plus is a transdiagnostic intervention based on acceptance and commitment therapy. It's aimed at adults. Now, you can probably see from the picture here that the unique part about Self-Help Plus is that the actual instructional content is delivered through a pre-recorded audio, with the sessions facilitated by 2 trained facilitators. So the aim of the facilitator is to motivate the group, support the group, ensure that people remain engaged, ensure that people remain safe. But the actual instructional content on activities such as unhooking, grounding, values-based activities, all of that comes through the audio. Now, the benefit of this is that we can deliver it to up to about 30 people at a time. So, this is where we start getting into those interesting ideas and models where we can sort of look to start chaining interventions together in some sort of step care approach. For example, people could first take Self-Help Plus. It could be taken by many people in a community. We'll see from as based on the research, it would help a number of people. And then anybody who might need help after that could then receive a more intensive one-to-one or individual intervention. Now, Self-Help Plus has been scaled up across Ukraine as a stress management intervention. It's been used across all the different regions, and there's over 100 NGOs who are aiming to deliver it. And one of the, I'd say, benefits or unique features of Self-Help Plus is that we've seen it being effective both for reducing psychological distress, but we've also seen in trials that it works as a prevention intervention. And we saw a reduction in people going on to be diagnosed with a mental disorder when they'd received Self-Help Plus in one of the randomized controlled trials that we delivered. So that's a group-based version of self-help. And then really the other forms of self-help that we have available and that we've developed and tested are really primarily guided forms of self-help delivered either through books or through the internet or through web apps. And it's important to say here that we've really tested the self-help interventions primarily as guided interventions, and we've developed a guided self-help model that was seen as effective with multiple now different self-help interventions. And this comprises of about 5 15-minute telephone calls delivered weekly from a trained non-specialist helper. So the idea of each of these calls is that a trained helper calls up the individual who's using the self-help. They aim to motivate them, ask them any questions or answer any confusion that they might have about content. Maybe signpost them to other support if there's other issues going on, and they ensure safety. So the helper isn't really there to provide the content. All of that comes from the self-help. They're really there to motivate and support, and then really answer any clarification questions. And so if you think about it, if we think about 5 minutes to 15 minutes support, that's 1 hour, 15 minutes of contact with a person. Now, if we add on note-taking, preparation, things like that, we might go up to an hour and 30 minutes per session. But we see that the amount of time that a helper might need in order to deliver a self-help intervention is greatly reduced compared to what they might the time that might be taken if they're giving a one-to-one session. So you can start seeing how this might well be something that can reach more scale across a much larger geographical area, such as a region or a country. And there's extensive evidence for self-help. I mean, again, it's maybe something that won't suit everybody. We saw in this network meta-analysis that for symptoms of depression, group, telephone, and guided self-help treatments were all effective. But for some people, guided self-help may be a little bit less acceptable. So there is still, it might not be suitable for everybody, but it's something that would allow us to meet the needs of many people. And we also saw, again, in another fairly recent meta-analysis from 21, that both guided and unguided self-help were associated with changes and improvements in effectiveness. But we see that probably when it comes to more moderate or severe forms of depression, that then guided self-help might be more So the first intervention I want to mention from the self-help area is something called doing what matters in times of stress. Now, this is, again, based on acceptance and commitment therapy, and this is actually a simplified book version of Self-Help Plus, the audio group that I mentioned a minute ago. And doing what matters in times of stress actually started life as the Self-Help Plus book. So people would attend the Self-Help Plus groups, and they'll be given a copy of the book to help them continue to practice and so on. And it's an illustrated book. It's very simple and easy to read. The illustrations take you through the main 4 aspects. So it started life as part of the Self-Help Plus intervention, but we released the book during COVID in response to requests around stress management and similar issues. And really the intervention's taken on a life of its own, and it's now been tested in a couple of randomized controlled trials. We only have post-test data because it was tested as part of a step care model, but we're seeing it increasingly used as an intervention itself or as a guided self-help intervention. And it's available both as a book, and it's also available and has been tested as a web app. And I should also mention at this point, a lot of the interventions that I'm mentioning, firstly, they're all available on the WHO website. They're under open access and Creative Commons, but already there are many translations available, and the translations vary for each tool. But for example, for Doing What Matters, we have over now, it translated in over 30 languages. So I'd really encourage you to have a look at the WHO website if you're looking for resources, particularly in different languages. The next intervention I want to mention is something called Step by Step. And this is an intervention we developed at WHO primarily for adults with depression. Now, it started life really as an electronic version of Problem Management Plus, but over its development course, it shifted much more into using behavioral activation, stress management, and other techniques focused primarily on people with depression. It was designed primarily as a digital intervention from the start, and it follows. It's a narrative, illustrated story where you follow a character as this character goes and receives help from a health professional for their depression, and as they do that, you as the user then learn some of the different techniques, and there are sorts of behavioral activation tables, there are stress management exercises, audios and things to help the user improve and learn these skills. It's been tested in Lebanon, and it's also been adapted and tested in a number of other countries, including in China and including with overseas Filipino workers. I just want to talk you through here really a little bit more about the trials that were done around Step by Step. So it was an intervention that was tested in Lebanon, and we developed it with colleagues in Lebanon from around 2015, and we developed it iteratively over a number of years, and we were conducting the randomized controlled trials in 2020 when Lebanon was undergoing a number of different emergencies. This was a collapsing economy, political turmoil, a big refugee crisis. There was an explosion in Beirut, and there was obviously the COVID-19 pandemic. Now, despite these issues, our colleagues there, the Ministry of Public Health, did fantastic work in running these trials. National Mental Health Program there were leading this, and we managed to conduct 2 fully powered trials of Step by Step. And despite everything that was going on, we saw really good results. We saw that on the primary outcomes of depression and impaired functioning, Step by Step showed significantly better outcomes, and also better outcomes on the secondary measures. Now, on the basis of this, the National Mental Health Program of the Ministry of Public Health decided to implement Step by Step as a national service. So it now runs as a national service that anybody can implement, anyone can access for free. It's being provided as a guided self-help model, so with the 15-minute per week telephone call that I mentioned. And here are just some initial results from the early scale up. And really, I'm sort of showing this slide primarily to just sort of show what happens when we use self-help. So a lot of the time we might imagine that self-help is useful for people with mild problems. or we might think that everybody might improve, by going down a few percentage points or going down a category or so. But actually, when we look at this table here, we see that actually the people who improve vary. So on the top, we have the yellow dots are moderate depressive symptoms, blue, moderate severe depressive symptoms, and red is severe depressive symptoms. And this is the categorization of people when they came into step by step. And on the bottom, we can see where those figures move to. So, certainly when it comes to low intensity interventions and self-help, they're not a solution for everybody. We saw that 18% of people showed complete remission. And we saw that overall, 45% still had moderate or above depressive symptoms. So there were still many people there who needed additional support, but there was many people there who had been helped. So we can sort of see there how self-help can really play a role in helping us to manage huge needs and also manage the time of specialists and more specialized people in a different way. So that's a little bit of a quick tour of the main interventions that we have available at WHO. Now I want to just very briefly touch on implementation. So I mentioned before that we've released a psychological intervention implementation manual, and this is a manual that's been developed to support the implementation of non-specialist delivered psychological intervention. So again, it's not really just here about implementing WHO interventions. We're aiming for this manual to be useful for the implementation of any evidence-based psychological intervention in any setting where it's delivered by non-specialists. And we've aimed to try and make this a simple manual and a helpful manual, and something that is useful for program managers, implementers, and a wide variety of people. And it really, it has these sorts of 5 chapters. So it really takes you from the start of planning through to the monitoring and evaluation cycle. The planning chapter, very much about how do you choose an intervention, what type of team do you need around it, what sort of planning do you need to make, financial resources, workforce, and so on. The adaptation chapter really outlines a process for adapting a psychological intervention. So although we know that these scalable or low intensity interventions are effective and are effective in many different settings and with many different populations, they do need to be adapted and culturally adapted to the context. So, and this chapter really talks you through how to do this. Then we have a chapter on workforce, which is about how do you prepare and sustain a competent workforce? How do we use competency-based training, competency-based assessment to support that? We then have a chapter really about how do you actually implement the intervention? So how do you identify people? Do you identify people through screening or through primary healthcare clinics? Do you do adverts on social media to sort of encourage people to access services? It really sort of talks about all of these different aspects of delivery. And then finally, we have a section on monitoring and evaluation, and both what you might monitor, what you might evaluate, and how you might use the data that's collected. Now, I should say also, when it comes to the identification, assessment, and delivery chapter and the planning chapter, in there as well, we talk a lot about the different models that might be used for implementing psychological interventions. And obviously I've mentioned step care, and I'm going to talk about that a bit more in a second. But there's also other models such as like collaborative care. So, but we're thinking here about, got to really think in a systems based way. It's not so much let's just implement this intervention, but let's think about the system around it. Let's think about how we access people. Should we be doing this over the telephone with people? What happens if we provide telephone-based therapy? Does it mean that we can reach a far greater number of people across a bigger geographical area than if we're asking people to come to a clinic? Or can we do a hybrid of both? So it's really about helping people to start thinking about these different approaches that can be used. And each chapter has a lot of information, but at the front of each chapter, you have these key messages. So for example, here for the planning section, we see It says about, map out the available services, think about multiple stakeholders, including people with lived experience and community representatives. Think about the models, maximizing efficiency. Now that we have this range of different interventions available, we're now thinking much more about, okay, well, how do we implement these? What needs to implement them? What are the barriers towards implementation? And what are some of the models that might help people get better coverage and meet the needs of more people? Because I think really, one of the things is there's been many examples of these such interventions being successful in trials. We have some very good examples of scale up, but we really need more, and we really need to find ways where we can use a suite of different interventions available and that are out there to meet the needs of different populations and meet the contextual needs as well. And just to give you a little sense of some ideas with that, oops, let's see, yeah, that's right. So I'm just going to show you the two very briefly, two models or two ways these interventions have been used. The first one was in Iraq, where both Problem Management Plus and Doing What Matters in Times of Stress were delivered at the same time. Now, Doing What Matters in Times of Stress was developed with delivered with the guided self-help telephone call that I mentioned, and was given to people particularly when they couldn't attend for the longer Problem Management Plus sessions. And as I remember, it was also delivered to adolescents. So it was a way of overcoming some barriers. And what I like about this model is that we see that, we can sort of see the effect sizes there. This wasn't a randomized controlled trial, but we can sort of see that we see some decent effects for DWM, Doing What Matters, and also for Problem Management Plus. But the important thing, I guess, here is that had these implementers just delivered Problem Management Plus, there would have been a whole number of people who just wouldn't have received any sort of help. So this is really just a way of thinking in a flexible way about how we might best meet the needs and support community. And this is the second one, again, this is a form of inspiration. A second model. So this was a trial that was done in Europe as part of a research project looking at the impact of COVID-19 on healthcare workers and many other populations in Europe, and how we might prepare for future pandemics. And in this, there was a randomized controlled trial conducted where colleagues came together a digital version of Doing What Matters in Times of Stress, so the web app that I showed you earlier, with the second step of Problem Management Plus. And what they found in this trial was that this stepped care model was effective. It helped reduce anxiety and depression in healthcare workers in Spain. But what we did see also, we look on the left-hand side here, is that 3 and 4 participants needed to step up to PM Plus. So we had 25% of people didn't need help after this, but we had a lot of people who did need to step up. So again, this shows us that there are benefits to self-help, but it shows us also that for many people, more intensive interventions might be needed. So we've got to think carefully about balancing resources and balancing needs, and how we best address those different aspects. Now, you would have all, or many of you may have seen the talk last year on Equip. I'm just going to very briefly mention this before we go to questions. So really, this is about the question of how do we ensure quality. So we've talked about the interventions, we've talked about implementation, but when you have specialists, CBT therapists and similar, we might go through some form of licensing or accreditation. When we're working with non-specialists, in many places, there isn't such accreditation or licensing. So, the question really was, well, how do we help to ensure quality? And this is where the Equip project was born. And really, Equip aims to improve the quality of psychosocial and mental health helping skills. It's aimed very much at trainers, supervisors, and program managers. So it's to support the trainers. And it's a range of different competency assessment tools to assess competency, as well as other resources to support competency-based education. And all of this can be found for free on an online platform. Best way to get there is to search for W.H.O. Equip. There's a lot more to say about Equip, but I'm just going to very briefly go through it. But just to give you a little bit of background, the whole Equip project, and particularly the Equip tools, were developed through a range of different systematic processes, a systematic literature review, expert review, and then building consensus from the field. It's undergone testing in multiple sites around the world. And we've found from the research that using the Equip tool, that's associated with improvements in helpful behaviors and reductions in potentially harmful behaviors. And also these tools can be very flexibly and easily applied to any training that you're doing. And it's not just for non-specialists, it could be used with anybody as a way of organizing feedback, organizing understanding about what somebody's competency is. So I think these tools started life very much as focusing on psychological interventions, focusing on non-specialists. And as we've sort of seen things evolve, we've seen that actually they're useful for any helping interaction and anybody really at any level. Now, there's many different tools, and I won't go into all of them, but the sort of foundational one is something called ENACT, or Enhancing Assessment of Common Therapeutic Factors. And as you can see here, there are 15 different factors under ENACT. On the bottom, we have your very foundational ones, which are your engaged competencies, non-verbal communication, verbal communication, confidentiality, and so on. Second level up is about assessment-based competencies, and the third is about support. Now, depending on what intervention you're delivering, some or all of these might be relevant. So, for example, with Self-Help Plus, not all of them are relevant because it's a very light intervention and we wouldn't expect the facilitator to do all of these things. So we focus primarily on the bottom six. So for each of these, we have the different behavioural skills that you might look out for. So these are used alongside role plays or even in vivo assessments. And basically in the role play, the helper may take part in this standardized role play, and you as the trainer basically mark off what you see happen. So on the left here, we have unhelpful or potentially harmful behaviors. And under empathy, this is things like being critical of the client's concerns, being dismissive. Then we have basic helping skills, so being warm, friendly, and genuine, and so on. And at the top, we have on the right-hand side, we have advanced helping skills, like asking clients to reflect on empathic statements. We laid it out like this because really it helps us to understand really the harmful behaviors and to really identify those and help people understand that they're there, provide feedback to our trainees, and help people improve. So it's not really designed as a pass or fail measure, but more as something to help provide helpful feedback, constructive feedback, and very, very concrete feedback. And we've seen this be useful in many different settings. So that's me coming to the end there. So really just a few closing thoughts, I suppose. I mean, we see that scalable psychological interventions, we've seen through the research, we've seen through implementation, they can have a meaningful impact. They're not a solution for everything and for everybody. More will still be needed. So we still need to focus on educating people, pre-service training, building up the skills of supervisors, specialist support, and similar. But they're one part of the puzzle, I suppose. There are a variety of interventions out there from WHO and from many other colleagues and partners around the world. And many of these interventions fit different contexts. And it's about really trying to move us towards using evidence-based interventions. Now, for anyone wanting to sort of start these things, I'm really sort of always sort of say, it's possible to start small and then build from there. So, if somebody doesn't have the capacity or the resources to deliver something like Problem Management Plus, maybe there's a way of starting with self-help or guided self-help. And really, I guess one of the other ideas here is that more people can be reached by perhaps combining some of these interventions, thinking carefully about the context, than if we just use one approach. So thank you all for your time. I hope that's been useful and interesting. We'll move on to questions now. This is my email. I think it's also gone into the chat. But yeah, please feel free to reach out if you have any questions or need any more information. Thank you.
Thank you, Dr. Carswell. That was terrific talk. I've asked people if they have any questions, but I guess while people submitted, I guess one question I had was, how do you decide which of the evidence-based interventions to start working on and then developing a psychological intervention that the WHO puts its stamp on?
How do we
Yeah.
decide?
Sounds like
Yeah,
you
interesting.
did problem solving, and then you went to behavioral activation. So how do you make
Yeah,
those decisions?
no, it's a good question. So, I mean, for WHO, the first step is the guidelines. I mentioned the MHGAP guidelines. So
Right.
anything that we develop have to be based on a WHO guideline. So back in 2011, I think it was, maybe a bit before that, we had updated guidelines, and they made the case for multiple psychological interventions. So, for example, IPT was recommended, CBT was recommended for different problems, guided self-help was recommended. And so based on that, we then were able to develop these different interventions. Now, we developed Problem Management Plus, CBT-based sort of intervention, because the evidence was there, the good approach. It's something that people are very familiar with, but we didn't want to just have just CBT interventions. So we also worked with our colleagues to develop, well, not develop, but to develop a WHO version of Group IPT, which
Yep.
has fantastic evidence and is used in many different places. And that was for those parts. Then really, it was very much about, okay, even with these interventions, there are so many needs. So how do we reach scale? How do we reach the need of many more people? And that's where we move more into the self-help and guided self-help. And then with ease, we need an intervention for sort of children or adolescents, for young adolescents. So it's very much about sort of filling gaps, and having a suite of different interventions. I wouldn't say there's probably a grand plan from the beginning. I think these things have very much evolved to now where we have these multiple different interventions for different places.
Got it. Thank you. One question we have is, wonderful presentation. One of our panelists has written, one of our attendees has written, I have two questions. Are there citations for the papers describing the trials for the various WHO interventions available on the WHO website? If so, where? And the second question is, or if you want, you can answer that first question if that's easier, Dr.
Yeah,
Carswell.
that's a good question. I think we're in the process, I think, of putting together a page or a place where all of the different citations are there. I mean, they can all be found by generally by searching the name of the intervention. They're normally in the manuals as well. But it's something we're working on, because we want to have one place where they are all available. But at present, they're not obviously available on the website, unfortunately.
Got it. And the second question is, with regards to the step-by-step intervention in Lebanon, is the Lebanon Health Ministry continuing to fund the lay providers who do the 15-minute phone calls? Can this intervention and other interventions by the WHO continue to be used when there isn't any human support available, which can be common in low-income, unstable settings?
Good question. I mean, obviously what I think one of the biggest issues facing any mental health or psychological intervention is funding. A lot of the time, the different interventions are funded either through the research or through scale up through different means. The aim is really to have health ministries take them on, and so our aim is to try and make interventions as sustainable as possible. So the guided self-help intervention really, we're hoping that they're going to end up being maybe deeper than some of the other different interventions, but we can't always know. They can be delivered without guidance. So, for example, step by step has been tested with this guided model. There's also papers coming out about it as an unguided model. And really, what I'd really love to work on next and sort of see is like this 15-minute model we started with. What would happen if we took it to a 5-minute model? I don't think that may be practical, but what would happen if we took it to a 3-session model or a 2-session model? So how can we you know, how can we make these things a bit more sustainable, a bit easier to implement? So there's, I think, a lot of there to be thought about, and this is, you know, all of this is out there, so that it's also out there for researchers to use and to start answering some of these questions.
Yeah, absolutely. Another comment and question. Thank you for your presentation. The goal of distributing resources freely is both generous and helpful to society. I'm wondering how you have implemented this into existing training programs, and if you have an example. We currently have the problem that step care, which is called HIPs in New Zealand, is only delivered by existing workforce who are already qualified. I'm interested in how we transfer skills to people who are not qualified, such as doing a generic bachelor in social sciences.
I mean, I think this is a we're sort of starting to sort of see how this happens, but what I'm coming across is that one of the big barriers to this in many countries seems to be either regulations or licensing, or who is allowed to sort of deliver these supports. So there are a number of sort of barriers there. I mean, I think this is where the UK model is actually quite a good model in terms of sort of seeing how these things can be done. So there's a 1 year post-bachelor course where you get trained up in these interventions, and I think that could be looked at, you know, as a model, and as a, you know, almost taking that model, but even maybe simplifying it a little bit. So instead of a year-long course, people are maybe trained in some of these non-specialist interventions. So we haven't really got examples of where it's been done fully yet. We're starting to sort of see these things. And it's very much about, I think, providing the non-specialists with some form of experience and support and supervision whilst they're maybe in an undergraduate program, and running that, say, through a university clinic or something like that. But these are some of the ideas that we're sort of exploring and trying to sort of see work. And I guess it's the thing, now that we have all these interventions available, it's now a time where people can start working on these models, I think.
Yeah, absolutely. One question is about, can we apply the intervention in Vietnam?
Yes, absolutely. I mean, I think some of the tools are already available in Vietnamese, and if they're not available, then they're under Creative Commons, so they can be translated. I mean, like I sort of said, there is a cultural adaptation aspect, but the manual outlines that, and very much we've sort of seen success with the interventions being translated and adapted for different cultures, and perhaps the stress management exercise might be slightly different in one culture to another, but there would be, I think, nothing stopping that.
So yeah, I think you kind of dealt with it a little bit in your answer in here, but the next question is, what are your thoughts on the cross-cultural applicability of the CBT approaches in these non-Western settings in terms of engagement of users and suitability for local models of mental health?
I think I think it's an interesting question. I mean, certainly when we look at the evidence, we see that the CBT models have been used in multiple different cultures, but it's always after adaptation. And I think also our experience with our own experience with sort of using CBT models in the intervention is that there are, you know, it's a wide family of different approaches. And maybe some of the approaches that we might use in CBT in the US or the UK, more of the sort of, you know, thought challenging models or things like that, more complex aspects. Perhaps some of those they may not work so well across cultures. What we've found though is that the, you know, things like behavioral activation, things like a problem solving or problem management approach, things like a stress management breathing exercise, those sorts of aspects, if designed in the right way, we've found can work very well across different cultures.
Got it.
But as again, like I said, it is all about adaptation as well.
Sure. Another question is, in your opinion, what is the promise of AI, generative AI, and large language models for providing digital mental health interventions in low-income settings like your chatbot work?
I don't think we've got enough time to fully answer that. It's a great question. It's something I'm interested in, excited about. I think there is promise. I think the first thing though that we need to do is, and I think we need to probably do this quite quickly, is test out these models. Like, you know, let's take not a very well designed, wonderful thing that's been run by a great company that spent loads of time developing it. But what happens when people start using ChatGPT, which they're going to be doing and probably already are doing? What if we test that as a model and see how that works? So I think they need to be tested for safety, efficacy, and we need to really understand how well these work. And if they do, then we can start looking at ways. But I think there's huge potential there. But a lot of research needs to be done.
All right. There are two more questions. If I know it's five, if you
Yeah,
don't
sure.
bring them. One was a great presentation and resources for use in regions where specialist trained professional workforce is limited. I was curious whether interventions such as the friendship bench will be considered for adoption by the WHO on this program.
Sure. So it's the friendship bench. I mean, is really already covered by the by our guidelines. So we'll sort of see that as an evidence-based intervention. Just really unfortunately, due to time, we don't necessarily have time to always publish all the different manuals. But what we are doing is we're working with an organization called mhpss.net to try and develop let's call it an online repository of evidence-based psychological intervention. So what we want to do is for open access manuals, we want to, because at the minute, it's very difficult to find an open access manual, even if it's out there. We want to sort of try and create a central repository where these manuals can go, WHO manuals and non-WHO manuals alike. Because it's very much, I think, about access to these manuals. So we're sort of trying to address that by creating this repository where the friendship bench, narrative exposure therapy, all the others can sort of maybe go and be found much more easily than searching through different papers.
All right, thank you. And the last question, are resources updated in response to new evidence and are users advised?
So we update our guidelines every 5 years or so. So that would be one way that they're updated. In terms of the resources being updated, in terms of new evidence, I mean, there would be. I guess if we found evidence that was very contrary to, or they found they were harmful or anything like that, I'm sure we would be reacting to that. But it's not something that we've found with the interventions. But yeah, it would be something that we would be aware of and keep an eye on.
Okay, great. Well, thank you. I think those were all the questions. I know people are very interested in the resources. So definitely go to the WHO website. They'll be there. We're also putting the recording of this talk on our website at the WCCBT.org, and we'll also be putting the Psychological Interventions Manual and all the links to the WHO. You can also go through there to get to the WHO if you're not able to find it on the WHO website. So either way, you'll get to the WHO website. So thank you so much, Dr. Carswell, for that lovely, informative talk. You can see that by the questions that people have really enjoyed it. So we really appreciate your time. I know it's late in Geneva, Switzerland. So a special thank you to you for staying up late and educating us all. Thank you.
Thank you, Dr. McGinn, and thank you everybody for your time and attention. I hope it's been useful, and yeah, I hope these are useful for you because they're there to be used. So thank you.